Hello and welcome to another episode of the Melbourne Athlete Development. Today, I'm very fortunate to have with me all the way from Italy, from the University of Padova, Dr. Caterina Fede. Caterina, thank you very much for being here today.
Thank you. Thanks for the invitation.
So, to give some context to the conversation, can you introduce who you are and what you do?
Okay. I'm a biotechnologist. I work at the University of Padova in Veneto, in the northeast of Italy. It's one of the most old university of Europe and Italy.
Mm,
I am a biotechnologist, and I started to work about nanotechnology. So a totally different field of research
hmm.
with respect to fascia. But 10 years ago, I started to work and to understand the microscopic aspects of the fascial tissue. So all the cells that populate the fascia and how the fascia change in physiological and pathological situation. And so to integrate the gross anatomy, the macro anatomy with the microscopic aspects in which I'm involved in.
Okay, because I'm all about fascia. I speak a lot about it on this podcast. I do a lot of talks and presentations here in Australia. But
Mhm.
fascia is a topic that I don't feel like has had a lot of exposure, particularly here in Australia. When I think about
Mm.
my own undergraduate studies, I'm a physiotherapist. We didn't really learn much about fascia at all, and in fact, even when you think about going into the dissection labs and looking at cadavers, often the deep fascia and the superficial fascia is removed. And it's something actually that it's only recently where we've had a big increase in a lot of research in fascia. And I'm actually interested to hear your perspective because you obviously have done a lot of publications in this of how much do we know about fascia and how much has it been an increase in research in fascia over the last 10 to 15 years?
Yes, the fascia at the first beginning was considered only a white envelope for the muscles, and
Mm.
so it was totally ignored also by the medical doctors. But if you search, for example, in PubMed, the number of publication about fascia, you can see that in the last 50 years, 40 years, the number of publication was around only 100, 200 about fascia. If you put the name fascia,
Mm.
only 100, 200 per year, and it is very, very low number. Then, I think that in the last five, 10 years, the number starts to increase a very, very lot. I think that in the last years, the numbers reached 1,000 and
Mm.
300 publications. So you can understand that now the interest about fascia, it's increasing in the world very fast. There
Mm.
is still confusion about what is fascia, can be considered fascia, and the different characteristics. But it means that in the past, a very important part of our body was totally forgotten, and now we are in the period in which we are trying to understand step by step what it is and what function it has.
Mm. Yeah, and I think I know for again, as I mentioned, I didn't really learn much about fascia at all during my studies. And at the moment we don't talk about it. You don't see it in musculoskeletal models. It's
Mhm.
always muscle tendon, but you don't actually talk about the fascia itself. And I actually think something that's also very important to highlight is when we often people use the term fascia, but we probably even need to specify now different types of fascia. And
Yes.
specifically, and we'll talk a little bit more about, say, muscular, the visceral, and the superficial fascia in particular.
Yes.
But I'm interested to hear a bit about some of the research you've done because I have spoken to some of your colleagues before on the
Mhm.
podcast, Professor Carla Stecco
Yeah.
and also Assistant Professor Antonio Stecco about
Mhm.
fascia and the biomechanics. But you've done a lot of research of looking at the cellular and molecular components of fascia as well. Can you talk a little bit about some of the research that you've done to better understand some of the components of fascia, and specifically the deep muscular fascia we'll start with, and thinking about it, what that tells us about its role within the musculoskeletal system.
Okay, about the muscular fascia, first of all, we have to distinguish the aponeurotic and the epimysial fascia, because the aponeurotic is able to connect different part of the musculoskeletal system and to transmit the muscular force over a distance, whereas the epimysial fascia, it is closely connected to only one muscle. It envelopes only that muscle. So it means that they have different characteristics and different roles. Surely, as you have already mentioned, the aponeurotic fascia works to transmit the muscular force, but thanks to the collagen fibers. But we have to mention that there is also the hyaluronan inside the aponeurotic fascia. The hyaluronan permit the correct gliding of the fascial layers with respect to the muscle. So it is another important key element. We have to consider, for example, that the fascia are also usually innervated, so they can work in the pain perception and also like a proprioceptive element. So the aponeurotic muscular fascia, it is like a large proprioceptive element which is able to feel all the tensions coming from the associated muscles. If we think about the epimysial fascia, we can consider that the epimysial fascia envelope and protect the muscle spindle. So it works in the motor coordination because it permits the muscle spindles to work properly. They has to be able to glide, to feel the to strength, to stretch. And obviously, if the epimysial fascia, which contains them, is able to protect them and to permit them to feel the correct tension, the motor coordination works properly. If the epimysial fascia becomes thicker, becomes rigid, it means that the muscle spindles is not too able in the proper way, and this is what happens probably with aging. So the capsule of the muscle spindles becomes very rigid and the motor coordination is less in the older people with respect to the young people. So also, if we consider only the muscular fascia, we have to distinguish the two different muscular fascia and the different elements which compose the muscular fascia, the collagen, the elastic fibers, the different type of collagen, because also the collagen can be formed of more rigid collagen fibers or less rigid collagen fibers. So we have to consider a lot of elements.
And I think the thing that I think of straight away there is if we want to understand the muscular system, we cannot separate it from the fascial system because, as you mentioned, both the epimysium and the aponeurotic fascia have multiple receptors, whether it's the muscle spindles with the epi and the perimysium, or also proprioceptors within the aponeurotic fascia, which provide both afferent feedback that influence motor output and coordination. One question I wanted to ask you is you briefly mentioned then about the impacts of aging on fascia. And I know
Yes.
you have done some research looking at this. Can you elaborate a bit more about what we know aging has, the effect aging has on the fascial system?
Sure. Thanks to Professor Carla Stecco and the collaboration with another PhD student from China, Dr. Shenglai Fan, we studied in animals and also in humans the effect of the aging. And in all the samples that we analyzed, we found that when we are young, but young it means very young, so till 20 years old, more or less, we have much more hyaluronan, much more elastic fibers, the collagen that is less rigid, so we have much more collagen type 3 and not collagen type 1 that is the most rigid. Then we start year by year to lose these characteristics. So the perimysium becomes more thicker, but not only more thicker, but also more rich of collagen type 1. That is the most rigid one. At the same time, we lose the collagen 3, the elastic fibers, and the hyaluronan. And so it means that all the muscle fibers are enveloped in a more rigid extracellular matrix and fascial tissue. And this means probably that can explain the loss of motor control and motor coordination of the older people.
Okay,
We
so
don't know if with the movement this can be a reversible process, but surely with the aging there is a physiological change of our fascia.
okay, so the stiffening of the tissue is suggested to then may explain why we see changes in, say, coordinative function, because it essentially reduces the sensitivity of those mechanoreceptors like muscle spindles or proprioceptors within your poneurotic fascia, correct?
It is correct, but it also means that the fascial tissue becomes thicker, so the gliding
Yes.
of all the structures is less.
Okay.
And so it is not only problems of the muscle spindles of the mechanoreceptors, but all the fascia. So I think that the gliding is reduced and the stiffness is increased, is most rigid, and more thicker. And so the movement, the pattern of movement can change.
Can you elaborate a little bit more about sliding? Because, well,
Mhm.
and you probably do a better job than I will, because one of the really important elements for the normal physiological function of fascia is the
Mhm.
mechanics of how it moves. So can you actually explain what you mean by sliding and the importance of it?
Yes, we have to think that if we think about the muscular fascia, we have to consider that is formed by 2 or 3 dense connective layers, very rich in collagen, but
Mm,
these layers are separated by a thin layer of loose connective tissue. This loose connective tissue is different, is very rich in water, in hyaluronan, glycosaminoglycans. There are more vessels, more adipocytes, and we found also the fasciacytes, these rounded cells that are able to synthesize hyaluronan. The hyaluronan is a key element in the fascial tissue because permits the correct gliding of the fascial layers, this kind of movement of the fascial layers and of the fascia with respect to the underlying muscle. We have demonstrated that the hyaluronan in a healthy fascia in adults remain the same, constant, is the enough amount which permit the correct gliding.
mm,
But with the aging or also with some other factors like changes in pH, in temperature, this amount of hyaluronan and the viscosity of the hyaluronan matrix can change. If the viscosity increases, it means that the gliding is less because this loose connective layer becomes a little bit more jellified, less liquid, and
yes.
the hyaluronan starts to also to increase some links with other proteins and becomes more rigid. The
Mm,
rigidity decreases the gliding properties of the fascia and changes the properties of the fascial tissue.
okay.
For example, we have to think about the temperature.
Yes.
When when it is performed the manual treatment, the local temperature in that site increase of some degrees, only 2-3 degrees, but this increase in temperature is enough to permits a less viscosity of the hyaluronan matrix and to increase the gliding. At the contrary, the change in pH, in acidic pH, increase the viscosity of the hyaluronan matrix, and we feel our muscles and our fascial tissue after for example, an intense exercise, much more rigid because the acidic pH change the viscosity of the hyaluronan.
You mentioned then, so aging will increase the stiffness because you get an increase in collagen type 1 relative to
Yes.
collagen type 3. You get a reduction in hyaluronan too. Do we know how we can actually avoid these changes? Like, is it aging itself that causes, say, dysfunction of how fibroblasts and fasciocytes maintain the tissue environment, or is it due to a lack of movement, or do we have any understanding of what variables actually influence these changes?
Related to the movement, there are not so many works published.
Mm,
There is only one work which demonstrates that with eye mobilization of animals, these changes in the epimysial fascia is much more. It becomes more stiff and more thick. There is also one other paper with MRI in which the authors demonstrated the intramuscular connective tissue, and they compared the old and young, trained
mm,
and untrained. And so they demonstrated that there is an increase in the intramuscular connective tissue with in the older, but probably it can be reversible because the trained old people have again a decrease of this intramuscular connective tissue. I think
mm.
that there is a physiological change in all the people, or trained and untrained, because also if you think about our skin, it is normal. We lose the hyaluronan, the elastic fibers with aging. And the same, I think, that happens in the fascial tissue. But obviously, with the nutrition, with the movement, probably we can help to have a better fascial tissue. But it is not
Yeah.
already demonstrated.
No, and that seems to be an area that we really need to understand better because I think of, say, the adaptation of muscle to nutrition, different types of mechanical stimulus. We have a very good understanding of the physiological changes to lots of
Mhm.
different types of mechanical stress and nutrients, but we don't seem to have much of a body of evidence yet to understand how fascia changes and adapts to different types of mechanical stimulus and diet as well. Mm.
Yes, the fascia can have different stimulation. They are very adaptable.
Mm.
So there are physiological changes, as I mentioned before, so the pH, the temperature, the aging, but there are also other molecules and stimulation that can fill the different environment of fascia and change the fascial tissue. We
Mm.
can think about drugs. We can think about sex hormones. We can think about mechanical stimulation. For all these factors, we have demonstrated that the fascial cells are like centroid cells. They have in their membrane some receptors that feel what is happening outside, and so they can create like a cascade of signaling inside the cells, which can produce a specific answer, and this answer change the fascial cells. So I can mention, for example, the sex hormones.
Mm, mm.
Different levels of sex hormones can produce different levels of collagen type 1, collagen type 3, elastic fibers, and change the fascial environment.
Could you actually elaborate on that and discuss some of the differences you see between, say, males and females with their connective tissue system?
Okay, we have demonstrated that the fascial cells express the receptors for the sex hormones. It means that they are able to feel the amount of sex hormones that there are in the extracellular environment. We have also divided the female group that we studied in two groups, the premenopausal and the postmenopausal women. And as expected, we noted that in the postmenopausal women, the amount of these hormonal receptors is less. Is physiological because the hormones is reduced and also the receptors are reduced. But what we have also demonstrated is that according to different amount of estrogens, the cells change the production of the collagen and elastic fibers. So during the peak of the ovulation, so when the estrogen is very high, so during ovulation, but also during pregnancy, the amount of collagen 1, that is the most rigid, is less. And they're increasing the collagen type 3 and elastic fibers. This means that during ovulation and during pregnancy, the tissue is more soft.
And this is something
More,
that I think too probably makes sense when you think about injury risk for females
yes.
depending on their menstrual cycle as well, and the stiffness or lack thereof of certain like ACLs as an example.
Exactly, because also some authors demonstrated that the injury of the anterior cruciate ligament, for example,
Mm,
is much more during the ovulation
mm,
period, because the tissue is more soft. That is a good characteristics, but it means that also the stability is less.
mm,
So we have to pay attention to the joints, to the posture, to the stability. So probably also adapt according to different sports the exercise to the different period of a woman.
mm,
At the contrary, after the menopause, when the estrogen is less, the fascia becomes more rigid. So there is much more collagen type 1, and this can explain the physiological changes of a female during the menopausal transition.
mm,
Obviously, we have analyzed only one hormone. That the situation in vivo is much more complex, but I think that the take-home message is that a balanced hormonal situation is good, but we have a lot
mm,
of peak and change in hormonal levels, the fascia change
mm,
and becomes more stiff or more soft. In the next future, I started last month, we want also to analyze the androgen receptors, so the
mm,
male hormones. Obviously, in the male, I expect that the variation are less in the fascial tissue because the hormonal levels in the male remain more or less the same for all the life. Is in the female that we have a lot of variations during the period, but also according to the age of a woman.
There's have you heard of the researcher Keith Barr? Like Barr. He's done a lot of research
Mm,
into tendons and looking at
okay.
response to tendons to mechanical load, but I know he's also looked at some dietary stuff as well. So, for instance, collagen
Mhm.
as a supplement in addition to mechanical loading. And I remember hearing him on a podcast. I'm assuming he's um, had some published research on this. I'm looking at things like soy and soy protein and its effect on tendons because
Okay.
soy is very high in things like phytoestrogens that may have a similar physiological role in the body to estrogen itself. And I'm pretty sure that he was saying that it does make it the tendons more elastic or proliferates the amount
Okay.
of collagen. I can't remember exactly what. So it's interesting, and I mean, this is all just um, something I guess we probably have more work to do in terms of understanding, but understanding that both it's very responsive to mechanical stimulus, but also then to chemical or hormone stimulus as well is a really important factor to understand its adaptation.
Exactly. I think that we have to think about the tendons, the ligament, but also to the fascia. And the
Mm,
chapter of fascial training, so movement and
yes.
fascia, it is very, very interesting. And I think that we have to change our way of think about also sports and fascia. Yes.
Yeah, and it's something I've actually spoken to some of my colleagues about because I work with athletes myself. And obviously, when you think of athletes, there are different types of athletes. And if you think of an extreme where you can think of, say, someone who's more of the slower endurance type athlete and someone who's more the really fast sprinter.
Mm.
And we know that there's differences in muscle profiles where the endurance athlete will be much more of that slow twitch type fiber. The fast athlete will have much more of the fast twitch fibers. But I do
Mhm.
wonder about the fascial profile. And, I don't know if there's been any research looking at this, but I often wonder where for the sprint athlete, I imagine that they have a great ability to be able to absorb and release a lot more energy in their fascial system to generate much higher amounts of force, where maybe the endurance athlete has much stiffer tissue that makes it much more metabolically efficient to then run long distances, and as an example. So I imagine over time we'll probably get an idea of different types of fascial profiles and how fascia responds to different types of stimulus long term as well.
Yes, also the mechanical stimulation, we have demonstrated that change the fascial environment. So we performed an in vitro experiment, but I imagine that in vivo is the same. So when we apply a mechanical stimulation on the fascial cells, we improve the production of new extracellular matrix. So it means that we improve the remodeling of the fascial tissue, the regeneration of the fascial tissue. So the cell starts to produce new collagen fibers.
Now, we've talked about the muscular fascia here, but as I mentioned briefly before, we have different types of fascia, and I know you've done some research both in looking at the visceral and the superficial
Mhm.
fascia. Can you
Yes.
talk a little bit about the visceral fascia? Is the visceral fascia, the muscular fascia, as you mentioned, it's highly innervated. We know that it has an important role in maintaining um, the loose connective tissue, as an example, to maintain sliding mechanics, and it's highly innervated in mechanoreceptors. Does
Mhm.
the visceral fascia have similar characteristics to the muscular fascia, or is it quite different and have a completely different role?
Okay, the visceral fascia permits to protect the internal organs, to allow the mobility, but at the same time to connect the organs with the musculoskeletal system, but maintaining an independent environment, because we have to think that during our daily life we don't feel all the movement of the organs, so
Hmm.
the vessels, the peristalsis of the
Mm,
intestine.
mm,
So it means that they are isolated, they are able to move, so the visceral fascia allow their mobility, protect them, but isolate them from the external environment. And we have to think also that the visceral fascia can be divided into two groups. So again, like the muscular fascia, also the visceral fascia is different. If we analyze the pericardium or the Gleason capsule of the liver, they are totally different. You can
mm,
see during dissection that the first one, so the pericardium, is very thick, and it is more fibrotic, more rigid. The Gleason capsule is very thin, and it is not easily separated by the parenchyma of the organs.
mm,
This is because these two examples of visceral fascia, which I mentioned, are of two different groups of visceral fascia. One is the investing fascia, one is the insertional fascia. The investing one is the liver capsule is in this group. The investing fascia is the fascia which envelopes an organ. It is in
mm,
closely connection with that organ, protect them. And it is less thick. It has much more elastic fibers. It is very hugely innervated.
mm.
At the insertional fascia is different, is thicker, is less elastic, and it has the role to connect the organs with the musculoskeletal system.
So, and actually, I was just going to mention, because going back to my university days when we learnt about internal systems, we can use the investing and insertional fascia. They're essentially analogous with the say, for instance, in the abdominal cavity, the visceral and the parietal peritoneum, or within the
Okay.
thoracic cavity, the visceral and parietal pleura. Correct?
Yes, you can also consider that the investing and insertional are like the aponeurotic and the epimysial
Yes.
of the
Okay.
muscular fascia is more or less the same. So the epimysial is closely connected to the muscle, and the
Mm.
investing is very closely connected to the organ. So they are part of the same group, but with different characteristics. We are at the beginning of the study of the
Mm.
visceral fascia. We have only analyzed some microscopic characteristics of these two different groups, and I made also work more related to the liver fascia. But I think that we have a lot of work to do to understand, because I studied the liver fascia, but I didn't study all the ligaments which connects the liver to the musculoskeletal system. So I think that they are very different, and this can help us to understand the visceral dysfunction and the visceral functionality.
Well, and I was going to ask a couple of other questions then too. Do we see similar characteristics with the visceral fascia in that it is innervated? Do we also see that it has different layers and that
Mm.
hyaluronan is present as well? Are there similarities in that regards?
Okay, no, the investing fascia is not made of different layers.
Mhm.
The visceral fascia that I analyzed before of investing fascia are
Yes.
only one layer. There is
Okay.
hyaluronan inside,
Mm.
but you have. It's not organized like the muscular fascia in layers which glide each other, because
Okay.
it is only one layer which permits to the organ to be protected.
Yes.
But it can change during pathology. This is very, very interesting. We don't know
Mm.
if it is the capsule first and then the parenchyma of the liver change, or if they change together, or if the investing fascia try to protect the organs that is losing its functionality. But we, for example, analyzed, thanks to a collaboration with the UPenn University and New York University, the liver fascia of some cirrhotic patients. And the capsule is totally changed. There are a lot of study about the parenchyma of the liver that becomes, it has a lot of fat infiltration, it becomes more rigid, more fibrotic, and so it loses the functionality, and it is not able to adapt to the different change of pressure of the organ. But also the capsule change. The capsule becomes very, very thick. It is surprisingly, because it is not the collagen amount which is
Mm.
increased, like we noted in the muscular fascia, but
Mm.
it is the organization of the collagen fibers that is altered, because the crimping is less. It seems that they are stretched.
Mm.
So the adaptation of the organ is less, and the hyaluronan increase. So the hyaluronan increase, but in the internal part of the organ, so at the border between the capsule and the parenchyma. I think that the hyaluronan, like as other glycosaminoglycans, it is also a key molecule for the communication between the cells, for the cell mobility. So it allows also a more infiltration of inflammatory cells, of myofibroblasts. So it is like an active zone at the border between the capsule and the organs,
Mm.
that surely have a key role also in the progression of the pathology. We think that surely the capsule collaborates with the loss of functionality, because the crimping, the stretching, of the collagen fibers, it means that the change, the adaptation of the organs is less. So there is
Mm.
high pressure of the
Mm.
organs, but also the capsule feel this high pressure. And
Yeah.
I think that we have a lot of work to do about the visceral fascia, but we have to consider the visceral fascia in pathology to understand how they change, because they have a role, and also can be also in the next future a target for some
Mm.
therapies.
Well, actually, I was going to ask that because, like, well, I was going to say two things. Was one thing you mentioned about the investing fascia of the liver, for instance, being stretched, and I think it's
Yeah,
important to highlight that the liver obviously changes its size throughout the day based on
yeah.
obviously blood being pumped through it, so it's in a more stiff, rigid state. But yeah, that was something I was going to ask: is is there potential for there to be therapeutic targets for changing the visceral fascia that may also have an impact on the function of the organ? Is that what's being looked at further or suggested maybe in the future?
Yes, we also want to analyze better the innervation of the visceral fascia because obviously there is a lot of autonomic innervation that can regulate the vessels, but we want also to analyze if there are nociceptors or how this autonomic innervation can change during some dysfunction or some pathologies. But we are only at the starting point of that.
You've mentioned a couple of times about that there is an anatomical relationship between the visceral fascia and the muscular fascia. And I'm
Mm-hmm.
actually interested, is there a theory, or there may be multiple theories for all I understand, about why there actually is a relationship between the two? Like, I mean, part of it I imagine is because the organs are suspended in the
Yeah.
cavity, which is like the abdominal, thoracic, pelvic cavity, whatever it may be. But I also wonder, though, too, is there any theories proposed about mechanical forces being transmitted from the muscular fascia to the visceral fascia that
Mhm.
influence the function of the organ itself? And I don't know if this might be speculative as well.
No, it's an interesting question. There are no
Mm,
demonstration about that, but I think that the insertional fascia surely communicate with the musculoskeletal system because permits
mm,
the connection of the internal organ to the musculoskeletal system. We have analyzed some suspensory ligaments of the liver, and we were very surprised to understand that there are so many innervation. We expected that there are some nerves, but especially autonomic fibers innervating the wall of the blood vessels. But we were
mm,
surprised to note also some big nerves which cross the suspensory ligaments. And so it could be interesting to understand which nerves where are directed, and surely
mm,
they are connected with the musculoskeletal system, but we don't
mm.
know anything else until now.
Yeah. Yeah, and look, it's something I think about too, of the importance of motility of
Mhm.
of the organs itself. And like, it's something that can be very problematic post abdominal surgery, say post
Yeah.
appendectomy or some type of laparoscopy where you can get adhesions formed that affect how the organs can actually move. And that seems to be something that's a very important element for its function, even just from the standpoint of it being able to dilate and go back to its normal state with, say, food moving through the gut during
Mhm.
peristalsis, as an example. Mm,
Yes, surely. And
mm,
I think that the visceral fascia was totally forgotten because during
mm,
surgery, obviously, the surgeons pay attention only to preserve the organs, the functionality of the organs. It's normal. But like when the surgeons make all the surgery, we don't pay attention to the scars that they produce in the
mm,
skin, but
mm,
it's the same also in the internal organs. I think that all the connection, all the innervation has to be maintained as much as possible to preserve the good functionality of the good connection of the organs with the
mm.
musculoskeletal system.
It actually makes me think too. Just to give you some context, I did a 3-year yoga apprenticeship when I finished studying physiotherapy, and yoga obviously puts your body in positions that you otherwise wouldn't do. And I know
Mhm.
from a yoga perspective, there's a lot of movements you do that are said to facilitate the function of your organs. And particularly if you go into deep twisting motions, you can appreciate that there's a lot of moving of the viscera within the respective cavity. And I often do wonder that of, and I mean, I experience it myself of like if I have, say, bloating because I've eaten something I shouldn't have, doing yoga seems to actually facilitate um, reducing some of the discomfort of that. And I do wonder how that can facilitate the function of your gut in this example to alleviate
Mhm.
pain or discomfort.
Yes, because when during sports we have to train the muscular force, the
Mm,
power, the strength,
mm,
but also all the fascial tissue. And the
Yes.
fascial tissue, it means the muscular fascia, so we can train the gliding of the muscular fascia, the good stretching of the muscular fascia to allow much more gliding and much more respect of the muscular force transmission. But we can think also to train a little bit the superficial fascia. With a superficial massage, we can improve the lymphatic drainage, we can improve the elastic components and the exteroception. But also with the visceral fascia, there are not so many parts. Probably the yoga is the most important one, which permits to our body to feel also the visceral organs, the internal organs, because obviously they are separated by the sensation with the muscle and the external environment. But with the training, with the yoga training, we can also improve the mobility of the organ and stimulate also the autonomic innervation. There are a lot of paper about the relationship between the autonomic innervation and the stress. The chronic stress stimulates the autonomic innervation and so stimulates the closure of the blood vessels. And the disease can be related also with much more fibrosis and also the loss of the immune system.
Okay.
So we have to think that stress, immune system, fibrosis, and autonomic innervation are all related. If you know that the autonomic innervation is very, very high in the visceral fascia, in the superficial fascia, obviously these elements are all connected. So surely with the yoga, you also reduce your stress. So it is multiple, there are multiple factors.
It's funny, actually. I've certainly looked at the relationship between, say, stress upregulating a pro-inflammatory state, and certain pro-inflammatory markers can provide signals for fibrosis. But I never considered actually the blood flow element, because obviously, if you have a reduction of blood flow, it creates a more anaerobic environment.
Exactly.
It creates more acidification, and that can also be a precursor for changes in the loose connective tissue and eventually fibrosis itself.
Exactly. Some ischemic pain can be related to the autonomic innervation and also to the chronic stress. There are works demonstrated that the stress closed the blood vessels. It means that can create also some circulation problems. Yes, can be influenced. And also you have to think to the lymphatic drainage, for example, related more to the superficial fascia, but it is all connected again.
When I think about fascia too, I think it helps really explain. Well, let's talk about the muscular fascia for a moment. It helps to really explain myofascial referral pain. So that
Mhm.
is how we can get tension in one spot that can radiate or refer symptoms elsewhere. And because I know traditionally referral pain in the
Mhm.
muscular system was related to the neurological relationship where you get feedback to the particular segment, and you can get you can get what's the word I'm looking for? You can get sensitization of a
Yeah.
segment above or below, and then that can radiate elsewhere. But there are limitations to that, because we see a lot of variation about where pain symptoms can radiate when you have myofascial pain, and it can go proximal to distal or distal to proximal.
Mhm.
Now, interestingly, when I think about the viscera, we get also visceral referral pain. And I know that actually there's been quite a few different maps of looking at the referral patterns of different organs in the body. And some of them actually do vary a little bit. They don't necessarily seem to follow the same pattern, which then brings in the question whether the referral pattern is due to a neurological relationship. Can fascia be an explanation for understanding how viscera refers to different parts of the musculoskeletal system?
Yes, I think that we have to separate the neurological components and the peripheral components because
Okay.
surely they are both involved. I think it's not related to the visceral fascia, but I'm thinking about the cannabinoids. The
Mm.
cannabinoids they are usually studied in a lot of organs of our body, and they are more related to the central nervous system. Yes, it is true. We can surely have an effect in the central nervous system, but we have demonstrated, for example, in the fascia, they can create also a very fast peripheral change of the fascia. So the cannabinoids start
Right.
to stimulate the fascial cells. They produce in a very, very fast way a lot of hyaluronan, and so it means that the viscosity, the gliding, at least temporary, of that tissue is changed. It is very interesting because it means that the cannabinoids can have also a very fast peripheral effect, changing the properties of the fascia, not only related with the central nervous system. Much more hyaluronan means less fibrosis and probably pain reduction. This can help to understand how the cannabinoids have an effect in the chronic pain. Because they reduce, at least temporarily, the chronic pain. I think that also in the visceral fascia, there is a lot of study to be done, but surely we have to consider the nervous components, but also the extracellular components. The same in the deep fascia. We change the amount, a lot of factors can change the amount of collagen, of elastic fibers, of hyaluronan, but also the innervation can change. In chronic pain, in chronic low back pain, for example, there is an anomalous stretching of the free nerve endings of the thoracolumbar fascia, which they are overstimulated, but also an increase in some nociceptors. So we have to consider both, because
Yes.
surely the nervous components and the extracellular components work together.
Yeah, and it's actually interesting. I do you know John Sherbel? Who I know he was
Yeah.
actually in part of our last year, wasn't it? During the conference that you ran there. I've had him on the podcast as well, and yeah, he's done a lot of work of looking at some of the neurological changes that can occur
Yes.
with regards to, say, back pain. But yeah, I think you actually highlighted the main point is it doesn't have to be one or the other; it can be both. So we don't have to fall
Yes,
into one camp.
exactly.
Yeah, one thing I actually just wanted to ask is more hyaluronan always better? Because you mentioned, for instance, then the
Mm.
regulation of the endocannabinoid system increasing hyaluronan that may acutely change the viscosity where it becomes more of a lubricant-like substance.
Mhm.
But then when I think about the concept of a densification,
Yeah.
which is the aggregation of hyaluronan binding to itself and then not binding to water, that can create a more viscous substance. So is that maybe the trade-off potentially if having a high hyaluronan acutely may have a positive effect, but then can lead to negative changes if it doesn't go back to normal?
It's a very, very good question, because the hyaluronan, you have to consider about the hyaluronan like a sponge that is able to link water. So if the sponge is rigid, it
Mm,
works not properly. If the sponge is very rich in water, is very soft, it works better. So about the hyaluronan, if you search hyaluronan in PubMed, you find millions of
mm,
publications,
mm,
because it is a very old molecules that during the evolution it is remained constant,
yes.
but it has a loss of different properties. The properties of the hyaluronan depends on the amount, but also on the molecular weight.
Yes.
So, in general, long chain of hyaluronan are better,
Mm,
uh, but low chain of low molecular weight, so small chain of hyaluronan, are much more inflammatory,
mm,
pro-inflammatory, pro-metastatic in the tumor, because the hyaluronan has a key role also in tumor, in metastasis, because it permits the mobility of the cancer cells and to create more angiogenesis and more inflammation and the progression of the metastasis of a tumor. So we have to consider both. In general, in the fascia, we noted that the amount of hyaluronan remain constant, is only 35-40 micrograms per gram of tissue. but the environment in which we have the hyaluronan can change. It could be more viscous, so more rigid, more gelatinous, or it could be more rich in water, less viscous, and permit the correct gliding. I think that the production of the hyaluronan after the cannabinoids treatment, it means, okay, we can create new hyaluronan because the hyaluronan has also a rapid turnover and
Yes.
change the environment. So removing the old hyaluronan that probably is more rigid, it has some links with the other binding proteins, so the environment is much more rigid. We can change that hyaluronan with a new one, permitting a good gliding.
Well, and that probably is a good segue into talking about the superficial fascia, because one thing I was going to mention then is that's probably then dependent on how well your lymphatic system is functioning to be
Mhm.
able to uh, get rid of, say, excess hyaluronan or other debris from the interstitium. So,
Yes,
can you actually talk a little bit about the superficial fascia? Because from what I understand, some people don't necessarily think the superficial fascia is a separate tissue structure. But can you actually
yes,
describe the actual anatomy of the superficial fascia, and then more importantly, its physiological role within the human body?
sure. The superficial fascia is closely connected to the skin, is
Mm.
a fibrous layer in the middle of the hypodermis. It works together with the skin for the exteroception and permits the separation of the exteroception to the proprioception that is more related to the deeper layer, so the fascia, the deep fascia, and the muscle.
And just to
Uh,
explain, exteroception is about sensory feedback from the external
The
environment,
external
correct?
environment, exactly.
Yes.
Yes. So the superficial fascia, it is connected to the skin. It works together and separates there is the skin, the epidermis, the superficial adipose tissue, and then there is the superficial fascia layer. At the first beginning, this layer was only considered like a fibrous layer with some fibroblasts, permitting only the feel of the external environment together with the skin, separating and protecting the internal layer. But more we study the superficial fascia, and more we discover that there are other characteristics. First of all, it is very hugely vascularized and very hugely innervated, especially of autonomic nervous system. In the superficial fascia, 34% of the nervous fibers are autonomic nervous fibers. So again, they can regulate the blood vessels of the so the vascularization of the superficial fascia, and so also we mentioned before the link between autonomic nervous system, chronic stress, immune system, and fibrosis. But
Mm.
also it has much more elastic fibers with respect to the deep fascia. In the superficial fascia, there are 13% of elastic fibers. In the deep fascia, only 1%. This is because the superficial fascia permits an elastic containment and the protection of all the blood vessels and the nerves which cross the superficial fascia. We have also demonstrated that the superficial fascia hosts a lymphatic plexus. We know that in the dermis there is a plexus with these big lymphatic vessels which run longitudinally, but then they run also in a vertical course to reach the superficial fascia, and in the superficial fascia they form a second plexus. So the superficial fascia surely works for the lymphatic drainage, and so has to be considered in some circulation problems, lymphatic drainage problems, in the lymphedema, for example. And also we have demonstrated that in the superficial fascia there are a lot of mast cells. The mast cells they were considered related to allergies, allergic phenomena. It is true. So that also the superficial fascia can be involved in the allergies. But the mast cells have also another important role. They regulate the inflammation and the immunomodulation. They have a very important role for the tissue renewal. So when there is a tissue injury, are the mast cells that regulate all the process to permit the regeneration of new extracellular matrix and the closure of the injury, of the scar. So they are related also with the scar formation. And so surely the superficial fascia has not to be forgotten. It's totally different from the muscular fascia. But for some dysfunction are more related to the superficial one and not to the deep one.
So yeah, as you mentioned, it's not necessarily high in collagen, so it's not necessarily playing an important role in terms of mechanical force
Mhm.
transmission. Do we? Or did you want to make a
Sorry,
comment
no,
there?
there is collagen obviously, but is
So yes,
organized in a different way with respect
okay,
to the deep fascia. It's not in layers, but is collagen in different direction, but
yes.
with more elastic fibers and with much more adipocytes, vessels, autonomic nerves all together. It's not organized in layer like the deep fascia.
Okay, because I was going to ask, do we find hyaluronan in the superficial fascia as well?
Yes, there
Okay.
is, but we didn't till now. We didn't analyze the correct amount. But I'm
Yes.
sure that it can change also, like changing the skin.
Because I mean, for me, I like to think about application in the clinical world and thinking about how do we get dysfunction in the superficial fascia similar to what we can get, say, in the deep muscular fascia, where changes to the viscosity of the
Mhm,
extracellular matrix changes the stiffness of the superficial fascia that lead to some type of dysfunction. And then for
mhm.
me too, I start to think about, is that then do we start to see dysfunction in the superficial fascia when we start to get things that influence our autonomic nervous system in a negative way? And like a good example of that may be stress related factor that we talked about before.
I think that also the superficial fascia is very adaptable. It change also with some early inflammation,
Mm.
also with bad nutrition. If you have bad nutrition, you can feel the tension in the superficial fascia. If you
Mm.
pinch the superficial fascia, it is immediately can have be a source of pain. But if you do like a superficial massage in the superficial fascia, also self massage, it
Mm, mm,
can be released very fast, in a very more fast than the deep one, because it is also very populated of blood vessels and blood cells. So you can stimulate an inflammation, can stimulate the granulation of the mast cells, and stimulate the lymphatic drainage also with the superficial massage.
Yeah, well, and that makes sense because I think, again, when we learn about different manual therapy techniques for lymphatic drainage, we're doing a lot more
Yeah,
superficial type work. So it makes sense in terms
exactly.
of the relationship to the lymphatic system is obviously much more superficial.
Yes, probably also the fibromyalgia can be
Mm,
related to the superficial one. There are no
mm,
demonstration, but I think that in the fibromyalgic patient, the superficial fascia can be very altered with respect to
mm.
the healthy one.
And I guess that makes sense also thinking about, I mean, there's a lot more to be done about understanding fibromyalgia, but it seems to be much more of a complex systemic problem related to autonomic dysfunction.
There is also surely the components, genetic components,
Yes.
the immunocomponents, like in lipedema patients. In lipedema,
Mm.
we demonstrated that the superficial fascia is totally altered, is more thick.
Mm.
It works together with the fat, because in lipedema patients, only the fat was analyzed till now, but we demonstrated that the superficial fascia is changed, is
Yes.
disrupted, is not well organized, is thicker. Um, so it works together with the fat adipose tissue, but surely is not the only component, because there is a genetic component. So the female are much more affected than the male. There is the metabolism, there is the immunomodulation, but surely we can add the step also of the fascial tissue to understand how the fascia works together with the other part of our body in the pathology.
You mentioned before about diet and feeling like tension in your superficial fascia. So are we talking about then the neurological relationship between, say, the internal system and the superficial fascia due to that the autonomic nervous system, I'm assuming? Is that that would be the speculation for why you see that? Where
Sorry, you can repeat?
I think you mentioned before that if you, for instance, eat something bad,
Yes.
you can get
Yes.
tension within the superficial fascia.
Yes.
And I'm assuming that the relationship that explains that is due to the autonomic nervous system getting
Mm-hmm.
a incorrect signal from your gut that then actually changes the superficial fascia system as
Mm-hmm.
well.
But I think also that the diet is related with uh, mast cells, immunocells,
Yes.
early
Okay.
inflammation, change of pH.
Yes. So it can be a chemical
Yes,
response. Yes.
yes.
Okay. No, that makes sense. Look, I'm very cognizant of time, Katerina. Thank you very much for being here. To
Thanks.
finish off, I always like to ask our guests about things that interest them outside of their professional work, because you're obviously thinking fascia, fascia, fascia all the time. Are there things that you like to do or like to learn about outside of fascia?
Okay. Thanks to this research, I've learned that all the things are connected together. So, related to
Mm.
the work, my basic research is very related to the clinical research,
Mhm.
and so this is also translated in in my way of think, the life and the other things. We are all connected. All the things are connected, and so the key element is the integration. The
Mm.
integration, and we have to change our way to think, because only because we always say it is always done like that in the past, but we have to wait to change our way of think, our way to 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 think about the life and the different aspects. So, like in my job, my basic research, it is immediately translated in the clinical research, and I learn
Mm.
from clinicals how to manage my basic research. So I
Mm.
think that integration and multidisciplinarity is the key.
Well, it's funny, like going back to talking about fascia, I think one, like clearly has a very important role within our physiology. But the
Mhm.
other thing it does do is, you hear so often, and I think particularly some of the older traditions like traditional Chinese medicine or Ayurvedic medicine
Yes,
talk about the connectedness of the body. The fascia actually provides a physical connection of the body too. And I think it helps to provide a bit more science and evidence to actually validate that claim. And I feel like because the body at the moment, I feel like medicine has become, and you see it's also within my work within the musculoskeletal system, everything has become segmentalized. Where it's like, you
exactly.
only specialize in the shoulder or the hip, or you're a gastroenterologist or you're a neurologist. Yeah,
Especially in
medicine.
medicine, the medical doctors are very highly specialized, but they think
Mm,
only in their segment. But we have to
yes.
change the way of think and to consider the body altogether.
Yes.
There is also another interesting field about body, fascia, and psychology. Uh,
Mm,
and surely it is all connected. It's more difficult to be demonstrated by the science, but step by step we can arrive also to that. We have to consider all the body in the totality.
yes.
And also, I think the personalized care is the key, because
Mm.
we are all different. And during the anamnesis of a patient, we have to consider a lot of factors, not only the pain, the referred pain, and the site of the pain, but all the body and all the different elements, hormonal, movement, old pathologies, the diet, and a
Mm,
lot of
mm.
things.
Caterina, thank you very much for taking up some of your time.
Thank
If people
you.
want to follow your research and what you do, can they? Are you active on social media?
On social media
Yeah,
about
like
my
do you
research.
about your research? Yeah.
Okay, some research are published in the facial manipulation site
Oh
because
yes,
sometimes we made a short communication.
yes. Oh yes.
It's,
You can find
it's
video. You can find videos of you actually on the Fascial Manipulation YouTube website. Oh,
yeah,
use a YouTube channel, I should say. Okay, perfect.
I think that the communication to the audience is a good point that we have to improve because we
Yes.
do a lot of work, but we understand that we have to translate it to the population and to the audience in a more easy way. I
And I
agree
think
with
also,
you.
yeah, and also getting the message globally because I know particularly in Australia,
Mm,
people haven't heard much about your research or Carla or Antonio's research, or to be honest, like even Robert Schleip and
yes.
all the other big researchers in fascia. And so, yeah, we have to use all these different platforms to try and spread the word. So,
Also,
thank
thanks
you.
to this kind of podcast, step by step, we can spread the knowledge. So, thank you for the invitation.
No, thank you. And again, just to our listeners, please do like, subscribe, please leave a comment. This really helps us to increase the message and spread the good work that some of our guests are doing. Thank you, Katerina.
Thank you. Bye. Have a nice day.
So,